Thanks very much. It's such a thrill to be here as somebody who's spent the last 2 decades focusing on a group of diseases that no one understands. It's really terrific to come and speak with thoracic surgeons because I've had just enormous good fortune at the different places I've been to work with spectacular thoracic surgeons, and they've always managed to somehow even make me look a little bit good. So what I'd like to do is figure out how to move this thing. Here we go. So what I'd like to do is take you through sort of the medical side of it, if you will, and focus really on, this is some conflicts of interest. I consult for drug companies that want to develop drugs for IPF. So what I'd like to do is talk briefly about sort of review the landscape of interstitial lung disease, where the surgical lung biopsy is really essential for an accurate diagnosis. And that's really the punchline. We're dealing with diseases that some of which you can cure, some of which you're going to die from, and it's really critical to be able to distinguish between those things, and the surgical biopsy, in my view, is absolutely essential. And how helpful is the high-resolution CAT scan? That's really revolutionized the interstitial lung disease practice, and I'd like to give you some insights into how we sort of sort through who we're going to biopsy based on the CAT scan. And finally, the importance of pathology and my perspective as a pulmonologist on what we really need from the biopsy. And then lastly, I'll just sort of touch on, who should we avoid from the standpoint of surgical biopsy. So I'm going to start with a case, a 49-year-old professor of biology who developed a rash and then started to get short of breath, had some cough, noted some hand swelling, basically had otherwise been healthy, no history of respiratory disease. Former smoker, this is when I was up in Connecticut, and so he was treated for Lyme disease like everyone in Connecticut is. He's a marine biologist and was an expert on coral, and he breeds Siamese fighting fish. One of the things about interstitial lung disease is anything can cause it. So sorting out red herrings from what's really driving the process is always a challenge. And he is a professor up at Yale. Has an office building that's like 300 years old, so he's got poor ventilation and trying to sort out, is that what's going on? So a couple points here, just that he had some crackles on exam, but he's pretty sick. You look at his lung function here, it's pretty horrific. His diffusing capacity, 31%, and when he walks down the hallway, his oxygen saturation is 72%. So what does X-ray look like? So bilateral mixed interstitial alveolar infiltrates, and the CAT scan. So the CAT scan is really fundamental in sorting out what we're going to do with these patients with interstitial lung disease. And what we see here is a peripheral distribution and traction bronchiectasis, these holes here in the lung. And these patterns, the high-resolution CAT, the patterns really determine, where we're going to go in terms of trying to figure out a diagnosis. And this is looking at the bottom of the lung. So a lot of remodeling. But what you don't see here, and I'll show you some more pictures, is what we call subpleural honeycombing. That's the whole key. When you have subpleural honeycombing, we have a pretty good idea what's going on. But when we don't, we have no idea, which means we're going to need a surgical biopsy to sort out what's going on with this patient. So in terms of the diagnostic evaluation, one of the challenges we face is we don't really have any gold standards for a lot of these diseases. We sort of make it up as we go along. And so it's challenging at times, but it really requires a whole amalgamation. We've got to actually talk to the patient, laboratory evaluation, the CAT scan. Physiology is actually enormously important. When I see my patients, walk them down the hallway, if their oxygen saturations fall down into the 70s or 80s, my next question often is going to be, how do you feel about a lung transplant? Whereas if your oxygen saturation doesn't drop below 90, you're going to live forever. So it's a really critical piece of information. And finally, the pathology. Pathology is incredibly important. It's also more important to find someone who can actually read the pathology, which is a challenge. So as we look through our classification, basically anything can cause interstitial lung disease. And what we're really trying to sort out is there something intrinsic to the lung, or is it something that is a systemic process? And so we can sort of sort through, granulomatous disease, but the main focus, and where I spend most of my time, are on what we like to call idiopathic interstitial pneumonias. And the terminology has evolved over the years. It's continuing to evolve, and it's not enormously helpful. But what is very helpful are the patterns on the CAT scan and the patterns on the biopsy, and that's what I want to share with you. So the key thing, believe it or not, it sounds easy, but it can be difficult. How long has it been going on for, and is it limited to the lungs, or is it part of a systemic illness? And we can really break down the diagnosis enormously by answering these 2 questions. So when patients come in quickly, that is to say, interstitial infiltrates over a short period of time. The thing we worry most about is what we call acute interstitial pneumonia, what used to be called the Hammond-Ridge syndrome. And it looks like ARDS. The only problem is it's come on over a few weeks or sometimes maybe a month or two. Eosinophilic pneumonia can come on very abruptly, and we love that because we can wave steroids at the patient and they'll get cured and they'll think you're wonderful. But infections and alveolar hemorrhage. So this is what the chest x-ray looks like in someone who comes in with acute interstitial pneumonia. Just bilateral infiltrates, and this is the CAT scan. We see sort of this diffuse alveolar filling process. And the lung biopsy, doing biopsies in these folks is challenging. They're on a ventilator usually. The mortality is 70%, and the treatment really is to turn down the volume on the ventilator in essence and hope for the best. But what the pathology looks like here is diffuse alveolar damage. And it's essentially just an acute wound. We don't see this enormously, but when we do surgical biopsy in these folks, we just worry very much about how they're going to do over the next short period of time. Patients that present more subacutely, and what I mean by that is they typically look like they've got a community-acquired pneumonia, but they've gotten a couple rounds of antibiotics and they're not getting better. That's when you wonder, is there something else going on? And bronchiolitis obliterans is sort of the main one in that category. But some of these other ones we can also see eosinophilic pneumonia, hypersensitivity pneumonitis, and I'm going to show you some pictures of these. But for many of these, we can't diagnose with the bronchoscope. We can go in, take 6 or 8 pieces, but we can't get enough tissue to really be confident of the diagnosis. And that's where we really need the surgical lung biopsy. And the VATS procedure has revolutionized it because it used to be a little bit of a hard sell for certain patients because the operation was, not trivial. But now with the VATS procedure, it's really made things enormously better. So this is what organizing pneumonia looks like. And when I see a CAT scan like this, I get all excited because I know I can essentially cure the patient. When we see these alveolar filling, these air bronchograms, this is almost pathognomonic of organizing pneumonia under the microscope. This is another example, these peripheral alveolar bronchograms. We love these because it usually means it's a plug of granulation tissue, which I show you right here. So this is a lung. It's essentially these are what are called Masson bodies, plugs of organizing tissue. It's actually collagen in there, but it, for the most part, melts away with corticosteroids. We have to be careful about how much we give, how often. We'll often use a second agent to minimize the toxicity, but more often than not, you can cure patients with this process. Hypersensitivity pneumonitis is another one. It can be challenging because people who have hypersensitivity pneumonitis, particularly people who have birds, are crazy, and they will not get rid of the birds. They'll lie. You have to talk to their spouses. They will not get rid of the birds. If you can get them to get rid of the birds, you can usually do well, but the problem is the birds. And this is what the pathology looks like. So what we see here are sheets of inflammatory cells, all of these sort of collections of blue cells in a pattern that's around the airways. Again, this is something that we can usually win the game with. And sarcoid can always look like anything. We can usually diagnose this with a bronchoscope. So when we get sarcoid with a surgical biopsy, that usually means the pulmonologist didn't do a very good job. It's a challenging disease with these big, massive granulomas. It can be difficult to treat, but by and large, most people do reasonably well with pulmonary sarcoid. Some patients will go on to get pulmonary hypertension and need a transplant, but it's really the minority. So one of the big challenges with interstitial lung disease is sorting out, is this a disease that's just in the lungs, or is it part of something systemic? And the real challenge is that sort of this interface between the world of rheumatology and the world of pulmonary, because there are certain instances where the lung is really the first manifestation of a systemic disease. And sorting this out is incredibly important because when it's an idiopathic pulmonary fibrosis, as I'll talk to you about, when we treat those patients with corticosteroids or immunosuppressive therapy, the recent evidence suggests that we do more harm than good. In fact, we can kill them. But in patients who have interstitial lung disease driven by a systemic process, we save their life with immunosuppressive therapy. So this is really where the CAT scans and the biopsies are enormously important in sorting that out. Some of these are very easy. Scleroderma is very easy to diagnose. Rheumatoid arthritis is easy to diagnose. But some of these polymyositis syndromes, and particularly what we like to call an undifferentiated connective tissue disease, we have no idea what that really means. It just suggests that there's a systemic process driving this. And so this is sort of the workup we'll do when I'm trying to sort out if somebody has an interstitial lung disease caused by a systemic disease or whether it's idiopathic. And this is sort of the panel of sort of rheumatologic tests that I'll get and try to sort that out. And one of the biggest challenges is that many patients are on statins, and statins can sometimes cause an elevation in one of your muscle enzymes, and this can be part of a relatively rare group of diseases that are called myositis diseases, and they can cause interstitial lung disease that can be life-threatening, and sorting that out can be challenging. This is what the CAT scan looks like in a patient who has one of these polymyositis syndromes. It's a very diffuse pattern. This is what we would like to sort of say kind of a non-specific pattern, and critical is, it doesn't look like idiopathic pulmonary fibrosis. And so if we can't make the diagnosis with serologies, we'll go on and get a surgical lung biopsy because we can't get enough tissue with transbronchial biopsies. And this is what the biopsy looks like in these patients who have systemic diseases. I love when I see this because that usually means, again, I'm going to be able to cure the patient. When we see this very homogeneous, diffuse collection of inflammatory cells, essentially no normal lung. This is a pattern that, to me, really suggests, and I'll see a lot of these patients after they've had their biopsy, and I'll look at this and I'll go, they probably got an autoimmune disease, and now I got to go search for it. But where really the crux of the matter is, are patients who present chronically, months, sometimes years, cough, exertional breathlessness, and the infiltrates are really just in the bottoms of their lungs. And really it's sorting out idiopathic interstitial pneumonias, and particularly idiopathic pulmonary fibrosis versus some of these other things. I'm not a big believer that aspiration really causes fibrosis. It certainly isn't good for your lungs, particularly after a lung transplant, but I've never been a big believer that it actually is a cause of fibrosis. So sorting it out, it really boils down to, once I've excluded a systemic illness, they don't have asbestos exposure, there's no good reason for them to have this process in their lungs, then it boils down to for essentially what we call idiopathic. And about 7 out of 10 times it's going to turn out to be idiopathic pulmonary fibrosis. It's also called usual interstitial pneumonia, which is a horrific term, but it refers to the pattern under the microscope for a lung biopsy, which I'll show you. But sorting it out between IPF and what we call nonspecific interstitial pneumonia, also another horrific term. But the key thing is that this is basically a fatal disease, and this is a disease that for the most part we can cure patients. And then there are some really, really unusual ones. These are caused by smoking, something called desquamative interstitial pneumonia, DIP. I don't think I've seen a case in 10 years. Respiratory bronchiolitis, which is again something caused by smoking. For the most part, if you stop smoking, this doesn't progress. And I talked to you a little bit about the acute interstitial pneumonia. So this is what it's all about. It's all about images. I spend all my time looking at high-resolution CAT scans and sorting out who do we need to biopsy and who do we not. And as you can see, they all look the same. And so just sorting out idiopathic pulmonary fibrosis with these peripheral reticular opacities and these sort of what we call honeycomb changes versus this nonspecific interstitial pneumonia pattern. This is really where the rubber meets the road, if you will, because distinguishing between these two is incredibly important. This is like telling somebody they have lung cancer and they're going to die, and this is like telling somebody, well, you're going to be fine, you're going to live another 20 years. And sorting those out is really, really important. But these are what these other ones look like, the DIP, respiratory bronchiolitis, and something very rare called lymphocytic interstitial pneumonia, usually seen in the setting of something called Sjogren's disease. So these patterns, sorting these out and deciding whether we need to go on for the lung biopsy. This CAT scan is absolutely diagnostic. Over the last 20 years, the only thing we've really gotten better at in terms of idiopathic interstitial pneumonias is figuring out how to hurt people less, in all honesty. We still don't have a drug yet. We're getting closer. We've got some phase 3 trials going on. But for this disease called idiopathic pulmonary fibrosis, this is really a tough nut to crack. Fatal disease of unknown etiology. It's not rare. There's over 100,000 patients in the U.S. with it. We don't have a drug yet. And right now, lung transplant is really the only effective therapy. The challenge is that, the average age for patients with IPF, is typically in your 60s and 70s. So it's a disease that rises dramatically with aging. It's very rare under the age of 50, and it's men more often than women. So if a woman with interstitial lung disease under the age of 50 does not have IPF. But this pattern right here, this is what we call subpleural honeycombing. You don't ever want to do a surgical biopsy in somebody with a CAT scan like this. Because when the bottoms of the lung look like this, we're not going to get any information from the microscope that we don't get from this CAT scan right here. And the transpulmonary pressures are awful. There's a chance for air leaks afterwards. You don't want to biopsy these people. When I was a fellow 20 years ago, we biopsied everyone. And now one of the things we've learned is there's subsets of patients you want to avoid that, particularly because we don't have a drug that's going to work, and really the only thing is lung transplant. So again, this is classic. We don't know why this happens, the periphery of the lungs, but this honeycomb, you can see why we call it honeycombing. It looks like a beehive cut on end. When you see this kind of a pattern, there is absolutely no reason to do a surgical biopsy. Nothing good is going to happen from this. This particular pattern. The problem is that patients don't read the textbooks, and they don't always present with these classic patterns. This is what the biopsy looks like from a patient who has idiopathic pulmonary fibrosis. It's called usual interstitial pneumonia for the very simple reason. In the 60s, two famous pathologists up at Yale called Lebo and Carrington, they looked at all the cases they could. They collected all the interstitial lung disease cases they could that they didn't have a cause. There wasn't any environmental exposure. They didn't have a systemic disease. And the pattern that the pathologists saw most often, they called the usual pattern. So that's where UIP comes from. It's the most common form of fibrosis when you have no inciting agent. And ironically, you cannot make the diagnosis without normal lung tissue in there. It's a patchy process. Even at very advanced stages, there are areas of the lung that look nearly normal. It's a very unusual process. But you have areas of dense collagen deposition right next to these areas of normal lung. And it seems to start from the pleural surface out. We have no idea why. But in patients who have very early disease, as you know, everyone gets a CAT scan pretty much every week now for any reason. So we're finding all these peripheral things we don't know what to do with. You're finding them with nodules. We're finding them with interstitial opacities. And out here at the periphery, we see these little lines. And if you blow this up a little bit, this is what the very early phase of this disease looks like. And when you biopsy it, and we love to biopsy these folks because we're trying to figure out, what can we do to prevent this from getting worse? You have normal lung, completely normal lung, areas of scar, and then in between, this is the cancer-like lesion in this disease. This is what we call a fibroblastic focus. And it's this collection of activated fibroblasts, mesenchymal cells, myofibroblasts that contract the lung down. But what you don't see is a lot of inflammation here. So this disease is really much more like a cancer than it is a chronic inflammatory disease. But you contrast that with this, okay? This CAT scan is virtually diagnostic of this other entity. Again, terrible name, another really famous pathologist looked at all these slides and said, this is nonspecific, meaning it's not UIP. So what this really translates to is not IPF. And that's really what it's all about, IPF or not IPF. And so these curvilinear peripheral reticular opacities, this pattern is very, very suggestive of what we call nonspecific interstitial pneumonia. We still like to biopsy these because we don't know enough yet about the process. So unlike that pathognomonic CAT scan where I showed you with IPF, where we probably do more harm than good with a surgical biopsy, in this particular case, it's really important because it can start to give us clues as to what might be driving the process. Is it a connective tissue disease? Is it a drug reaction? Are there birds that they're not telling us about? We can get some clues from the way the tissue looks. This is the extreme form of this. This is a patient who has scleroderma. We don't biopsy these folks anymore, but just this dense, but it all looks the same. That's the key to this. You have no normal lung. And here's another example. This is a woman in her 30s, again with this peripheral reticular patterns, but no subpleural honeycombing. And if you look under the microscope, this is what it looks like, this NSIP pattern. But compare this with the UIP pattern. So this is really what it's all about, because this patient, by and large, will do well with immunosuppressive therapy. This person we can potentially kill. So, and look, I mean, how, as you can imagine, these biopsies can be challenging to start, which is why it's so important to get multiple areas, particularly areas of the lung that don't feel so dense and scarred. The distal areas are what really help us. So these are the pattern recognition. So this is, when you see this peripheral sparing, you got a lot of tissue remodeling in here, but this is a pattern that is not going to show IPF very often. And under the microscope, we see this very, very homogeneous pattern. This is treatable. Now, this is another example of a peripheral reticular opacities, and this is incredibly curable. You wave steroids at this very cellular form of nonspecific interstitial pneumonia, and it melts away. Patient's happy, everybody's happy. You just have to make sure you don't kill them with the steroids. So really what it boils down to, I like to use the analogy of sort of impressionist art. You know, is it a Renoir or Monet? You know, and you need to be able to distinguish between these two because it fundamentally changes the course of the patient's life. And this illustrates it pretty vividly. If you have IPF, when I see my new IPF patients, you know I've basically got 3 to 5 years to we either get a drug that works, or I've got to convince them, you know, or the surgeons that they need to give them a new lung or 2 new lungs. Whereas if you have any of these other NSIPs, respiratory bronchiolitis, it's rare to lose one of these patients. So it's fundamentally important to get the diagnosis right. And the other point I mentioned is incredibly important. I do this on all my patients when I see them the first time. Walk them down the hallway. Or if they're busy in the PFT lab, I walk them up the stairs. And if their oxygen saturation doesn't drop, they don't have IPF. Where if it drops into the 70s or 80s, you've really got to start to have that discussion. How do you feel about the adventure of a lung transplant? And one of the things that I just also want to mention, because you're going to get called to biopsy patients who are getting worse, worsening breathlessness, their oxygen saturations are dropping, and they can have what we call an acute exacerbation of IPF. So this is a patient of mine who over 4 months, there's a 4 months difference between here. You got these peripheral reticular opacities, and look how quickly this has progressed. Biopsying these folks is precarious. When they're on that slippery slope and you do a surgical biopsy, that slippery slope can get accelerated. I'm not a big believer that surgical biopsy makes things worse, but I know I recently visited Singapore and the thoracic surgeons won't do surgical lung biopsies there on patients with IPF because they think it's too hazardous. I don't believe that, but it's just something to keep in mind when you're being asked to biopsy these folks that progressing quickly. This is the natural history of IPF, from the chest x-ray in the asymptomatic person to the end of the road. So it's a chronic fibrosing lung disease, no systemic illness, no exposure, the CAT scan pattern that I showed you about, the surgical lung biopsy pattern, 5-year survival is dismal. We don't have a drug yet. We're working on it. I'm hopeful over the next couple of years we're going to have things that work. But lung transplant is the only option at this point in time. So accurate diagnosis is essential, and as I mentioned, there's a recent paper in the New England Journal suggesting that immunosuppressive therapy in people that have honeycombing does more harm than good. And we do have clinical trials available. So with a biopsy of IPF, there are randomized, placebo-controlled phase 3, phase 2, phase 3 trials. So we have things to offer. We just don't have a drug that works yet. So back to our biologist, our professor of biology. Now that you're experts on all of this, when we look at this, what we don't see, it looks bad, definitely looks bad, but it doesn't have that peripheral honeycombing. So serologies, we get an isolated, one random, it's like, picking one out of a hat. One random serology. What does that mean? No idea. So we need lung tissue. So this is the surgical biopsy. And actually, it's kind of ironic, but particularly my good friends Tom Colby and Kevin Leslie at the Mayo in Scottsdale, the way they make the diagnosis, they see like 25 of these cases a year. They hold the slide up to the light. And if you can see normal lung in there, basically it's IPF. I mean, this is where we're at with our diagnosis of this. And what you see here is there's no normal lung. And there's these dense areas of blue cells, and you've got these plugs of granulation tissue. This is sort of an area of organizing pneumonia. Dense inflammatory cells around here. And as you zoom in on it, you see all these. So what is this? So I sent this to 3 different pathologists. I get 3 different readings, you know. But basically what it means is you need to give steroids. So the pathologist number 3 I like the most. Active fibrosing process, fits best with Buch. Focally eosinophils are prominent, but this is not a diffuse change. What does that mean? No idea. No idea what this means. So we give him steroids, right? Steroids don't help this fellow. So at this point in time, he was getting evaluated for a lung transplant. And then I added in this Cytoxan, immunosuppressive medication. And persisted. It took months, and then he started to get better. And here's what his CAT scan ultimately looked like. I have no idea what his disease is at all. But the reason I persisted with the immunosuppressive therapy was because of the surgical biopsy. The way that looked, it looked like something that could be responsive. And so we persevered, and he has really, really done well. So the last couple of points are that this is, again, coming from 20 years of being a pulmonologist, referring patients for surgical biopsy. From my perspective, it's indicated when the clinical presentation and the high-resolution CAT scan don't give me an answer. That is to say, I'm going to get something from the biopsy I don't already know. IPF is a fatal disease, and I need to exclude treatable interstitial lung diseases. It's essential. But here's the key. We need multiple biopsies. Whichever side is picked, I like biopsies from every lobe, obviously not both at the same time, and multiple sites. It's really key. And the diagnostic yield is greatest from areas that don't appear to be the worst in terms of how the tissue feels. Because when I get this back, the patient undergoes a surgical biopsy, and this doesn't help anyone. This is just end-stage scar. And so you've got to get the areas that are not doing this. The lingula rarely gives any useful information. Biopsy the tip of my lingula, it looks fibrotic. It doesn't help. And in terms of the caution with biopsying, patients with extensive subpleural honeycombing, those are the people over the years I've seen that we really look back, and I always regretted referring them for a surgical biopsy. If they're requiring a lot of oxygen, worrisome. If their diffusing capacity is less than 35%, it's very, very worrisome. And if they have a rapidly progressive course, that's also very concerning, because chances are they're going to have IPF, particularly if they're in their 60s or 70s, and they should be really getting evaluated for lung transplant, probably rather than getting a surgical biopsy. So at the end of the day, it's really all about multidisciplinary teams, and over the years I've been very lucky, and what I've found is when we all get together in the same room, the pulmonologist, the radiologist, the surgeon, and pathologist, we've learned things about the disease process. And what I'll show you tomorrow are some things we've learned really from these group meetings. But I'll stop there and take any questions if anybody has any. Thank you very much.